Okay, vulval disorders. Let's start with premalignant lesions of the vulva. Usually they occur on both premenopausal and postmenopausal women, but the median age is going to be 40 years. Even though there is a tendency shift towards younger women in the premenopausal period. There's no racial predisposition for vulvar intraepithelial neoplasm, and the disease usually is asymptomatic. So, pathogenesis of premalignant lesions of the vulva are usually caused by viral infections. The most important viral infection is going to be human papilloma virus. Types 6 and 11 are going to be responsible of causing genital warts or condylomata acuminata, and other subtypes of virus like 16, 18, 45, 31, and 52 are going to be responsible of producing intraepithelial lesions and also invasive neoplasia and cancer in the vagina, but not only in the vagina. They can cause, as you know, cancer in the cervix, vulva, oropharynx, perineum, and perianal anal areas. As you know, HPV infection, it is worldwide common. It occurs all over the world, almost 30 million cases of genital warts. It is estimated that 30 to 60% of the population has been infected with HPV. It's a sexual transmitted disease, and there's over 35 species that has been recognized. Usually HPV infections are asymptomatic, and they are versus sexually transmitted on both partners. Premalignant vulvar symptoms, usually the most important symptom is going to be pruritus, and which is seen in more than 60% of patients also with vulvar intraepithelial neoplasm. The diagnosis needs to, after inspection of the vulva, needs to be followed by biopsy. Essential diagnosis, and this is already vulval cancer. Typically, it will occur in postmenopausal women, and the symptoms are going to be irritation plus pruritus. We can also see dermatitis, and we can also see some special appearance lesions like cauliflower or hard ulcerated lesions in the area of the vulva. We need a biopsy to diagnose. The pathogenesis has to do with the way that the vulval cancer, usually the etiology is going to be HPV, and the spreading of the cancer is going to be done through the lymphatic spreads. We should be looking for lymph nodes in the inguinal or femoral or close to the external iliac, because there is where lymphatic invasion will occur. So vulvar cancer risk factors has to do with age, but also with HPV infection, smoking, inflammatory conditions of the vulva, prior radiation of pelvic and immunodeficiency. Vulval cancer, the most important one is the squamous cell carcinoma. There's another type, but this is the most important, and especially it is diagnosed in patients over 74 years. There's two types. One is the U vulval intraepithelial neoplasm, which it's divided in low-grade squamous intraepithelial lesion, LSIL, and in high-grade squamous intraepithelial lesion, HSIL. The other type is an HPV-independent differentiate type, which is called DVEN, or differentiated vulvar intraepithelial neoplasm. We have in the vulvar squamous cell carcinoma the two subtype. The usual type is caused by HPV, and it's also called the WAR-T or basaloid subtype. This is common in patients between 40 and 44. The keratinizing subtype is the DVEN and occurs more in elderly patients. Let's make a differentiation between HPV-dependent usual type and HPV-independent differentiated type. Okay, the usual type occurs more in younger patients and it's less likely to progress to squamous cell carcinoma. There is a history of smoking, and it is more commonly seen in basiloid-warty squamous cell carcinoma if it progresses. This subtype is usually positive for P16 and P53, is negative on immunohistochemistry. So when you take the biopsy, it is test for these two types of expression in tissue, and usually the dependent usual type is negative. This usual type will progress to an invasive squamous cell carcinoma only in 5%, even though it is responsible for 40% of all the vulvar squamous cell carcinoma. Let's talk a little bit about the independent one. So the independent one is the characterized one. It arises mostly not from HPV. It arises from other lesions like lichen planus, lichen sclerosis, that cause chronic dermatosis in the vulva. So patients with lichen sclerosis will need a lifelong monitoring due to the high risk of eventually develop a vulvar squamous cell carcinoma. This differentiating vulvar intraneoplasia is usually P16 negative, but it's going to be P53 positive in the immunohistochemistry test after biopsy. This differentiated type is going to be making up only up to 5% of the pre-invasive vulvar lesion, but has a higher rate of malignancy transformation. And it's going to be responsible for around 35% of the vulval squamous cell carcinoma. Vulval cancer histopathology, as I told you before, we have the squamous cell carcinoma that we already talked with the usual type and the differentiated type, but there's also the basal cell carcinoma, which is very rare. It's commonly located in labia majora and vulva, in the vulva, and it also causes pruritus. The problem with basal cell carcinoma is a high risk of recurrence.